Control of longevity in dementia, that is, control of how long one lives in dementia, not the quality of life in dementia, is possible, but with limited options. Some people want to exercise one of these options because they have strong convictions about their life not ending in years of severe dementia. The origin of their convictions, I'll leave you to imagine, but there are many real cases of people who've been up close to this problem who have strong convictions that their life, the arc of their life, not end with years and years of severe dementia. For those people with that concern, there are three options. Advance directives to refuse life-sustaining treatment, which are rather common, in fact, but they provide no assurance because some individuals in severe dementia never did need acute care, which could be withheld that would then lead to their death. Second, preemptive suicide or voluntarily stopping eating and drinking. It's a viable option for some, but it involves the sacrifice of some valuable time in life between the time of their last decisiveness to do this and the time when they think it's best that in the arc of their life the dementia not go on. And thirdly, advance directives to withhold food and water by mouth, which are the focus of this paper. Assumptions. I'm going to make a lot of assumptions for purposes of narrowing the discussion to what the interests of the demented person are who previously wrote the directive and what the consent dimensions are. First of all, the death can in fact be stopped by, it can come about by stopping eating and drinking quite comfortably. Now, I don't mean it's entirely comfortable, and there may be difficulties in particular cases, but there's a quite voluminous literature on how death by absence of food and fluids is a relatively comfortable death in most cases. Secondly, that voluntarily stopping eating and drinking is legally permitted. In the United States, it is definitely legally permitted. One has a right to do it. Various reasons for that right, one of which is the forced feeding would involve ultimately the imposition of medical treatment for artificially delivered food and water, and you can refuse medical treatment. So the person, if they're decisive, has a right to die this way. Third, advance directives to withhold medically delivered nutrition and hydration, a withholding which ensures death, no chances there that it won't, are accepted, both legally and I think by healthcare providers in many cases. And fourth, that the institutional legal barriers to implementation of a clear directive to withhold food and water by mouth are real but surmountable. We could have the whole discussion on just these, but I want to push those to the side and concentrate on the moral and philosophical issues. The fundamental challenge to advance directives. Bonnie Steinbach and I worked this out in a paper not only stating this challenge, which has been around for a long time, but trying to work out how to address it in the case of severe dementia. That work, and much of what I say here in the first half of this presentation is joint work that we did. The work on food and water is mine, not joint. I don't blame her for any mistakes on that. The person who wrote the advance directive has now changed in severe dementia. She doesn't remember writing the directive. She doesn't care about autonomy. She doesn't find her diminished life unbearable. Well, she might, but in certain specific cases, she doesn't. And she has little concern anymore that might have been one of the reasons for motivating her directive, that she would be for years a burden to her loved ones, and she didn't want that to be the way her life ended. She doesn't have any concern anymore about being a burden to loved ones. So what gives the then self authority over the now self? Dresser and Robertson say, nothing gives the then self authority over the now self. that the interests of the patient have changed, that respect for autonomy cannot override best interest because there's no current autonomy left, that the notion of precedent autonomy is just a misnomer. It refers to the person's previous autonomy, now which is no longer relevant. And that only treating the patient, is their conclusion, to satisfy her current best interest can respect the patient and be good care. One of the most famous responses to this, well-known responses, is by Ronald Dworkin in Life's Dominion. He does it by distinguishing two kinds of interests. He might have said, well, autonomy still trumps best interest, but he doesn't say that. He says, I'll grant Dresser and Robertson that we should operate on a best interest standard here, but what are the demented person's best interests? One has to distinguish, he proposes, between experiential interests that derive from first-order desires and beliefs. We just have those desires, just have those beliefs. And then our interest is in seeing those desires, beliefs realized and desires satisfied. But there are also critical interests, which derive from second-order desires, beliefs, and values. That is, desires and beliefs about the first-order ones, and evaluations of the first-order ones. One form of kind of critical interest derives from the fact that we often have highly reflective and considered convictions about what helps make my life good as a whole, and would make it less good, like 3 or 4 years of severe dementia at the end. Critical interests. It's important to note that they are not dependent on current experience, so that they can exist even now, when what satisfies them is no longer being experienced at all. For example, the interests of after death that are reflected in a will or in not demeaning the reputation of a person after their death. They can also exist even when what satisfies them is no longer being experienced as such. For example, in dementia, the person no longer experiences the lengthening of their life as something they don't wish to live, as something bad in the arc of their life. But that interest can still exist. It was formed previously by critical reflection. These critical interests compete with experiential interests in determining what constitutes a demented person's best interest. Now, Dworkin's, I think, indefensible move is the next move, which is that critical interests always trump. He says they trump because they're reinforced at the second-order level and are thus most important to people. They are what ultimately matters to a reflective human being. That not following them would be paternalistic, failing to judge a person's well-being as she did when competent. That following the advance directive, therefore, as long as we're clear what it is, satisfies a patient's best interest. If we don't follow it, we cannot claim to be acting for her sake. There may be other social reasons for not following it, but they're not that given her dementia and having forgotten the directive and all, not following the directive is acting for her sake. But do critical interests always trump? Why cannot more or strong experiential interests outweigh fewer or weak critical interests? Is a happy, demented person who still wants to live really better off dead? Dworkin, if the person had a strong, clear advance directive, would say, yes, they're better off dead. Bonnie and I raised the question in the earlier paper we did, wait a minute, they're not really better off dead. At least it's not obvious that they're better off dead. We would need to inquire about many further things before we would say that. Dworkin also cites a paternalism argument. We'd be saying we know better than the patient what's in her best interest. I think this argument is simply not correct. We'd only be saying, if we didn't follow the advance directive, we'd only be saying that we know better now than the patient knew then, when she was competent, what her current best interest is. But maybe we do know better than the patient that. Better than Dworkin, we think, is a sliding scale. How important are the critical interests represented in the directive? How much experiential interest in survival does the patient now have? The most important negative effect on experiential interests that withholding food and water is going to have is that the person won't survive. But how much is the person's experiential interest in surviving at that point? Our sliding scale is this. The authority of an advance directive about life-sustaining, that is the moral authority of an advance directive about life-sustaining measures, gains as the critical interest in not surviving is strong and the capacity to enjoy life and appreciate survival is weak. So we have to attend to what the experiential interest in surviving is. Suppose the person is not suffering much at all, that the person has a passive kind of minimal happiness expressed in, for example, as my late mother-in-law did, she would coo rather affectionately when her arm was stroked. Not always, but occasionally. And occasionally there would be a little smile. But also, there's little anticipation or memory. Weak psychological continuity within the person's own subjective life. They can't anticipate their survival tomorrow, and when they get to that survival tomorrow, they can't appreciate it as themselves having survived. Now, she wants, in a sense, this person, which is a quite severe stage, a very severe stage of dementia. There are more severe, but this is quite severe. She wants, in a sense, to go on living because of that minimal happiness and lack of suffering. But the subjective value of survival to her is low. She cannot expect living tomorrow, and she cannot appreciate surviving because she can't remember the day before. Suppose, therefore, that not only her experiential interest in survival is low, but that her critical interest in not living is strong because, this wouldn't be all cases, but in some cases, her directive is knowledgeable and clear about dementia. She understood what the stages and variety of dementia were, and she wasn't just saying, oh, if I'm ever demented, don't feed me. And she was clear about the point in the development of progressive dementia at which her life should not continue by not being fed. The directive conveys, furthermore, some of the beliefs about the person's life that lead her to wish not to live long in dementia. Most people can summarize those in a couple sentences. Acknowledges difficulties of interpretation. There will always be difficulties in interpretation, and says specifically, I entrust the interpretation to my proxy, and I've named a proxy. And this directive has also been reiterated relatively recently, perhaps in early dementia. Now, why critical interests and previous wishes must count in this kind of situation? Well, they should always count. But here, if they do count, they probably outweigh the weak experiential interest in survival. The best interest of the now self must include more than experiential interest. Otherwise, we will have treated the person as if she had never been competent. If we only go on best interest and ignore critical interest as part of best interest, we are treating the current demented person as if she had always been demented. This is Nancy Roden's very powerful point. But we must never treat a previously competent person that way. There must always be some significant difference in the way we treat a currently incompetent but previously competent person from the way we treat a never competent person in that same current state. Because there are elements of her life that have made her the person she is. We ultimately get back to a notion of her narrative identity as a person. What is the life she had, now still has? She has a conception of that life. She had a conception of that life. She no longer has a conception of that life because she's incapable of having any conception of her life as a whole. But doesn't that narrative conception of her life still count for something? Now, in end-stage dementia, the person is, let us say, not unhappy, but passive and unresponsive, and has little recognition of anyone as an individual. If critical interests are to have any weight at all, here they outweigh the experiential interest in survival, which is low. It's not zero. It's not that her life is either worthless or meaningless, but it is low, her experiential interest in survival. And if critical interests have any moral weight at all, they clearly must outweigh in this severe case, in end-stage dementia. Now, less than end-stage, severe stage dementia, this all gets very refined in the medical literature about dementia. Some eye contact, the person notices some sounds, expresses intermittent small pleasures, but also has little anticipation or memory, on the basis of which to have an appreciation of survival. A clear directive here, I think, also outweighs experiential interest. If it outweighs it in the first case, it outweighs it here. But that, of course, might lead us to say, well, there are going to be incremental changes all the way back, and we're going to end up imposing this, following an advance directive on a person who's only in early dementia, if they wrote such a directive. No, not necessarily. How much earlier, as we go back into less severe dementia, does the previous argument and the rodent objection apply? At some point, the person is engaged enough that experiential interest in survival is clear and significant. Even if the advance directive is clear and critical interest in not surviving is strong, we may say in those cases, not yet. And if we're saying not yet, rather than just a flat no and we're going to forget about it, we have not failed to respect the person who wrote the directive. This is Bonnie's and my argument in a previous paper. Now, changing one's mind. About advance directives, there's not only a then-self, now-self problem about interest, what the interest of the person is, and how it is shaped even now, possibly by interests that were formed, critical interests that were formed earlier. There's also the issue of changing one's mind, because a basic assumption about advance directives, and it should be our assumption, is that people may change their mind. You're never locked in. Someone in dementia may come to value new activities and find diminished life worth living. Certainly somebody in early and even early mid dementia might find that. Why should we hold her to her earlier advance directive? I don't think we should. There has been perhaps here a change. I say perhaps because it isn't all that, it isn't absolutely clear. Although there hasn't been an explicit change of mind about her directive, that is, she can no longer write a new directive. There has been a change of mind about what is valuable in her life. It is not just experiential interests. It is that she does have some capacity to evaluate those interests and care about them. So she wants to go to her art class, even though she paints the same picture every time, for example. The extreme position about changing one's mind would be extremely conservative, I think implausibly conservative, would be to say this: ADs are never valid since we cannot check out, once a person is incompetent, whether they've changed their mind. That time is gone forever. So therefore, we shouldn't follow any advance directives because they can't be sure they haven't changed their mind. I think that's implausible because there should be no burden of proof that a person has not changed her mind, or at least no burden of proof that's so strong that it blocks all advance directives. But an important lesson we can draw from that objection, though not following it to its extreme, is to say that reiteration is still important, and that a 30-year-old directive is not as good as a 3-year-old one. So a person entering dementia, since this is very contested territory, and the then-self, now-self problem is a real problem in implementation of a directive, A person entering dementia, knowing if they have a directive that they care about, they should reiterate it. And they should reiterate it often enough that we say, well, we got the person's last view on this when they were still competent. But of course, in dementia, at some point, it's no longer possible to change one's mind because there's not enough of a mind to change. One might have experiences, but that does not mean the demented person can change their mind about the values expressed in their directive. At that point, we need to revert to interest considerations. Following the AD does what the person wants, even if she no longer remembers wanting it, if the critical interests are strong enough to outweigh the experiential interests. I get back to the sliding scale. Now, all that is just the framework. Summarized, get to food in a minute. Directives for dementia should be allowed, enabling people to control the ending of their lives, but we need to ask three questions before we implement them. How strong is the current experiential interest in survival? How strong is the critical interest in not continuing to live at that point? And has the person changed her mind? Now, the point at which this all becomes important is only the point at which, in the directive, the person said they did not want to live. And that may vary from directive to directive. So when I say sort of the point at which we should consider acting on their directive, I mean that point. I'll get to one slightly different case in a minute. But 3 cases about food and water. First case. This is sort of a classic case about whether we should implement a directive. In severe dementia, now at the point that the advance directive said food and water should be withheld, the person desires food. She shows pleasure when fed, and she grimaces when she isn't fed. I take it that's pretty conclusive evidence that she desires to be fed. Second case. In severe dementia, also at the point where she, in her directive, said we should withhold food and water, the person is indifferent to food. Indifference being shown by the fact that we sort of had a trial, we tried withholding, and she showed distress. If she hadn't showed distress, she wouldn't be indifferent. In moderate dementia, or if she had showed distress, she wouldn't be indifferent, she would want to be fed. Third case, in moderate dementia, at a point earlier than the point stated in her directive at which she wanted food and water to be withheld, she resists food. She's not readily persuadable to take food, but a very artful caregiver can get her to swallow food by placing it and the right kinds of food in her mouth and being very patient. This actually happens in nursing homes with artful feeding assistants. But she resists. You can get her finally by a certain kind of, you can call it manipulation or you can call it not manipulation, but it's not persuasion, really. It doesn't appear to be persuasion. She can be brought to swallow. Should we sort of advance her directive and say, we're going to respect her apparent desire now not to be fed, even before her directive said to withhold food? I think we need to in these 3 cases, follow the same analysis. How much is the experiential interest in survival? How much is the critical interest in not surviving further? Or in this last case, in surviving one more stage yet, in dementia? And has she changed her mind? Those are the 3 important questions. The desire case. Experiential interest in survival is low, but not vanishingly low, for after all, she does desire to eat. Her experiential interest in not going, she does have an experiential interest in not going without food. She expresses distress or grimaces when she's not fed. On the other hand, she has a strong critical interest, let us suppose, in not now surviving, though it might be stronger if the directive spoke to the current situation with this dilemma. And some of us now writing directives say, yes, we speak to that. We're speaking to that in the directive. But suppose she didn't speak. The desire to be fed is not a change of mind about her directive. but it is a conflicting element in the patient's volition. So this is a really hard case. Depending on the details, we might well say not yet. The indifference case. Some experiential interest in not continuing to live, but it's minimal. Strong critical interest in not continuing to live, especially clear if the indifference possibility was addressed in the person's directive. Minimal experiential interest in living does not diminish her previously expressed critical interest in not living. And there's no evidence of change in mind in this case, of change of mind. Conclusion, in my mind, follow the directive. A more complicated case, premature resistance, that is before the point of dementia when the person said they wanted food withheld. Current experiential interest in living is significant. There's no suffering, the person is not unhappy, and there's some capacity to anticipate and remember. That's minimal, but there's some. The critical interest in not living is ambiguous. The reasons for the advanced directives trigger being stated as severe dementia were presumably authentic reasons the person had. She didn't state them as an earlier stage of dementia, which is the stage we're in right now, a bit before the more severe stage. But on the other hand, withholding food and water by mouth, the fact that it's in the directive at all shows strong critical interest in not living far into dementia. So the line is not far off when she wanted not to have lived. She does have a critical interest in surviving in the meantime, but how great is it? It's a very murky case on a number of scores. Premature resistance is not a change of mind about the advanced directive per se, or really about the advanced directive at all, but it's not surprising or inconsistent, given that she had this conviction that she didn't want to be fed going into dementia. Maybe, and in fact, she's conscious enough to say, I want to make sure it happens, it doesn't get left to the treachery of other people not doing it later. My intuition in this case is we just have to think of the upsides and the downsides and would probably have to decide on situational context. Conclusion. Directives must be accorded considerable authority. It is not acceptable to treat the previously competent as never competent. Strength of experiential and critical interest varies by current state, by the advanced directive itself, and by other previous wishes that proxies and family may be able to relate convincingly. Relevant changes of mind are possible in early moderate dementia, not really possible in severe dementia. Desire in the relevant sense of a change of mind that should affect the implementation of the directive. And finally, desire to eat in severe dementia is likely not a change of mind, but may indicate positive experiential interest in survival, which needs to be taken into account too. Now, if you're dissatisfied with the murkiness of these conclusions, let me note that at least I've argued for advanced directives, which can sometimes be followed, should be followed, to withhold food and water by mouth, and that's very controversial. Fundamental legal argument for it in the United States, at least sort of a kind of speculative legal defense of it, is that already voluntarily stopping eating and drinking when you're competent is robustly a person's right, and that advanced directives refusing properly specific and clear advanced directives to refuse artificially delivered food and water should be followed. You put those two together with the principle that people who become incompetent should not lose their rights, but only need to have their rights exercised by other people, and you conclude that even legally there's an argument for this, although my argument has not been primarily a legal one, but a moral one. Thank you very much.
Thank you, Professor Menzel, for the stimulating and provocative as well presentation. We come to the discussion time. Our discussant is Professor Sin-Yee. She is a faculty member of Department of Philosophy at the University of Vermont. She's a friend of mine. As I know, she is an expert in Confucianism and also an a feminist ethicist, right? Well, I would like to pass the time to Professor Chen.
Okay, thank you. So first of all, I want to thank the CUHK Bioethics Center for inviting me to this very stimulating conference. And I really enjoy reading Professor Menzel's paper. There's a lot of very nuanced arguments in the paper. Because of time, I would not be able to go through all of them. So I will only focus on two main issues. The first is the general problem of advance directive regarding dementia patients. The other is the more specific issue of withholding water and drink. I think the idea of advance directive is, in any kind of advance directive, is premised on the two selves problem. That is the conflicting or the probably conflicting interest between the then self and the now self. So one of the main position is Dworkin's issue, which Professor Menzel's paper discusses. Dworkin's position is to say that we should always respect the critical interest of a person, that the critical interest of a person always trump the experiential person of the now self. So that would mean that the advance directive should always be followed. Professor Menzel disagree with this position, and I agree with him on this point. I don't think that the critical interest should always trump the experiential interest. Instead, Professor Menzel offers a very nuanced, a very interesting, a very smart suggestion about how to balance the critical interest of a person and the experiential interest of the present self. So it's a kind of sliding scale or balancing approach. I have a lot of sympathy with that approach, but on the other hand, I think that there might be some other issues that we need to think more about. And I also think that I would like Professor Menzel to consider going much farther than he does. I would suggest that, well, maybe we should really just give very little weight, or maybe even no weight at all, to the critical interest of the previous self, and instead focus on the current experiential interest and the current will of the now self. So the reason why I say this is because I think that the now self and the then self, they are, in some sense, two different persons. So instead of just one person deciding on the issue of the future self, I'm trying to argue that there are indeed, probably, arguably, two different persons here. So if there are two different persons here, then one person has no more rights, no moral rights to decide for the other person. Okay? So if that is the case, then I would want to say that the then self does not have a moral right to decide for the now self. I want to show this. I want to show how the advance directive in the dementia case can be seen as different from the advance directive in other cases, like the terminally ill cancer patients case. I want to say that for the case of the terminally ill patients, the now self can be understood as an incapacitated self, okay? But for the case of the dementia, the now self is an altered self. So even though both selves can be seen as incompetent, okay, they have different relationships with the then self. So I would want to argue that in the dementia case, there are two selves, or at least that the then self does not have the moral right to make decisions for the now self because of two concerns. One is the epistemic concern, that's to say, can we really know what the now self is thinking? Can we really understand the person's world? Because the mental outlook of the person has undergone drastic changes, so drastic that it can be seen as an entirely different person. In the paper, Professor Menzel mentions a very interesting example. There's a woman who used to be very intellectual, but then when she developed dementia, she started to like something else, like yoga, gardening, music, which she did not like much before. So we can imagine if one day I develop dementia and suddenly I like Cinderella's story, then I would think that that is not really me. I never liked Cinderella's story, even when I was a child. So why would that person who liked Cinderella's story to be myself? Okay. And then there is also the ontological concern, which is to say that because of the huge mental gap between the now self and the then self, there seems to be very little in common between these two selves, so that we cannot really say that there is one continuing self there. In the case of the terminally ill patients, on the other hand, we can argue that, well, the person is just currently incapacitated, for example, by the depression or by the drugs or by the pain. But when the person has lapses from all those incapacitating influences, the person can still reconnect with her previous interests and desires. So if there are moments when the pain capsizes, the person can still ask about her family. She might still want to know what happened to her pet project, which she has taken for a long time. So that's why I think that in the case of dementia, the self has altered so much that maybe it makes sense to say that there is no one self there. So that therefore, the then self does not really have the right to decide for the now self, because there are two different selves there. So I think if that is right, then we can also have a reply to the Rodin's objection. The Rodin's objection is to say that if we do not respect the advance directive of a person, we would be treating formally competent patients as if they were never competent. But I would think that we can still respect the previously competent person's decisions in many different ways. Like, for example, how she want her financial arrangement to be made. We can still keep that. We can, for example, we can even have ongoing conferences to commemorate. A very accomplished, important philosopher, even though the philosopher is already having dementia. That is a way of respecting the person being competent and having accomplished. But for the very important question about whether this person would be allowed to continue to live or not, I don't think that the previous self, the then self, who has a so different moral outlook, who has so different mental outlook than the now self, should have the right to decide for the now self. So I will briefly comment on the idea of withholding food and water. I would think that withholding food and water is more like giving the patient the aid to die instead of just withholding medical treatment. The idea here is that the dementia patient, she is not independent. She cannot consume food on her own. So she really needs assistance in order to consume food. And for those people, if we do not give them assistance to consume food, I would think that it's really practically the same as not giving them food. Think about a very young infant. Just put the milk in front of the young infant. Are you feeding the infant already? Or are you, by not feeding the young infant, just putting the milk in front of her, you're killing her? Okay? So I think because those people, the dementia people, they cannot feed themselves. So therefore, and because they are placed in the facilities that is designed to care for them. Okay, so we have the obligation to nurture them, to take care of them. So therefore, refusing to assisting them in food is really very much like to kill them. So I would think that therefore, if the society has not given dementia patients the rights to have aid to die, we will not say that even if you have an advance directive to have lethal drugs given to you, then we will give it to you. If the dementia patients do not have the right to make advance directive to request lethal drugs, so I think we also, the dementia patient also does not have the right to be given this opportunity of withholding water and food. So I think my time is short. I will just, point out the summary here. I will not read it. So if you have time, you can just quickly look over it. Thank you.
Thank you, Professor Chen. Now we come to the Q&A session. Sorry. I have to give some time to Professor Menzel to respond to Professor Chen's comment.
I thank Professor Chen for a really substantive, stimulating, direct challenge on a number of scores. So, the perfect comment for our purposes. Epistemic concerns. Can the earlier self understand? In some cases, the earlier self doesn't understand much, a lot of prejudice about dementia. But in other cases, the person's been up close to it and understands a lot about what it is. Of course, never totally from an internal subjective point of view, but that's no different than our difficulty in understanding other people generally. Yes, an altered self makes for a tougher case than an incapacitated self. But why should that rule out the relevance of critical interests? She says there were two selves at that point. The self is so altered. I simply outright deny the claim that we are two selves. Try living with the view that we're two selves. The person could say, she's not my mother anymore. We expect, we ourselves as children say, she's my mother. If I didn't say anymore, oh no, she's not my mother, other people would justly criticize me. I myself, looking forward to my own dementia, think that I will be the same person. I'll be a very different person, but I'm the same person. And that's all Dworkin needs to make his point about critical interests. If Roden is correct about the fact that we should never treat a previously competent person, now incompetent person, like we would treat a never competent person. She says Roden could be followed vis-a-vis financial directives and advance directives, but not about life and death matters, and that would still be treating the never competent, the previously competent relevantly differently. Well, yes, it would be treating them differently, but it wouldn't be adequately differently, because one of the greatest concerns the previous person had wasn't about finances. No, it was about how long they live in dementia. And if that can't be considered, then we in effect have made them into the equivalent of a never competent.
Ms. Chen, would you like to make some few responses to Professor Menzel's response, or you want to wait? I collect some questions from the floor first. Okay, I follow Professor Fan, Raping Fan's practice, my friend. I will collect 3 questions first, and then I pass time to Professor Menzel to respond. And I see Dr. Chair and Raping and Han Lam. Sorry, maybe my direction is in that direction. Later, next time I will see from this direction.
Thanks for the very interesting talk. Actually, I've read your paper published in the Hastings Center report last year. before I come, I'd like to respond to one of the points which you only discussed on passing at the very end, and which is actually what Professor Chen, the second part of Professor Chen's response. I want to echo Professor Chen's response, which is about, you mentioned that respecting the advance directive in withholding all water and food can be legal, and you base your argument on the analogy of respecting voluntary stopping of eating and drinking. I agree that people should respect competent persons' voluntary stopping eating and drinking, in the meaning that we cannot force feed the patient, but we are not assisting the patient's suicide. So we are just respecting the patient's will to refuse oral food. And I've emphasized that oral feeding is classified as basic care. All right? And in the dementia situation, this analogy, I think, can only apply to those patients who refuse food. But for those who are indifferent, which is one of your examples shown, for those who are indifferent to food, and for these patients, they will eat when you offer food to them. If you follow the directive, then you are actually assisting the suicide or assisting the death. In that case, this will be analogous to advanced euthanasia directive, which we all know that it is illegal in most parts of the world, including the few states in USA which has legalized physician-assisted suicide. They do not allow advanced euthanasia directive. Even in Netherlands, which the law allows advanced euthanasia directive, it is uncommonly practiced because of a lot of concerns. So I think if you want to support your approach, you need to first of all convince people that advanced euthanasia directives should be supported before we can talk about refusal of oral food and water.
I'd like to offer a view on the third case, the premature resistance case. Yeah, I'd like to see how both you, Sin-Yee and Professor Menzel, think about that. I visited my hometown in mainland China, very north part of China, and last month for Chinese New Year. I talked to a few people about this kind of case. These were ordinary Chinese people, not medical specialists, not philosophers or ethicists. But they unanimously said, in this kind of case, if you are a good family member, if you are a good child, you certainly want to try to skillfully, by yourself or by some nurse or whatever, I try to feed your mom. And you ask him, what about the things that the mom previously, occasionally mentioned? I don't want to be fed in that kind of situation or so on. They would say, no, generally, they just mean, I don't want to trouble the families or other people too much. They really do not really mean they don't want to be fed, they don't want to survive anymore. If you are good children, you must, and their interest of such patients in that stage is dominantly clear that they wanted to be fed, it's good to feed them, and given your relationship of that's your mom, that's your father, and so on and so forth. They understand that the interest or existential interest of this patient at stake is so clear that the Dworkin's critical interest in this case seems to be nonsense. They understand that's just an excuse for some very bad family members try to abandon their dementia parents in a bad way. So I just like you to comment on it, that this view has some problem, or that's at least in the Chinese case that makes sense.
I'm just wondering how critical interests are determined. do we just take it at the face value? I mean, if they are autonomously determined, determined by the person, or do we judge whether they are reasonable? For example, there's an Islamic jihad who want to bomb up some building in New York City, and when he was young, and if he said, if ever I fail to be like that, okay, kill me. And suppose some years later he has developed dementia of some degree, and that person, the later person, just said, oh, what he did, what he said before was silly. He became a conservative. What should we do? I mean, I'm just wondering, how do we determine the critical interest?
First, I take very seriously your point that maybe one needs to go all the way to advanced euthanasia directives if one is going to go as far as this. However, in the United States, both caregiving situation and legal situation, advanced euthanasia directives are way off. They're off the chart. Denial by advanced directive of medically delivered food and water is very much on board. And voluntarily stopping eating and drinking when you're decisive enough, not necessarily even competent, just decisive, is legal. In that setting, and especially in very severe dementia, where there are problems eating, some people have said good care is really comfort feeding only. And if that is spoken to in the directive, we're getting quite complex now about the directive, but nonetheless, I think all these points are quite commonsensical. Then a directive. Comfort feeding only is not food feeding enough for adequate nutrition to sustain the body over a long period of time, but just what the person will readily accept, without extreme measures of getting them to swallow, tricking them, so to speak, to swallow. In that situation, people who really badly do not want to see their lives go years and years into this because they've seen others in it, have two choices. They can preemptively stop eating and drinking now while they're decisive, or they can write an advance directive and hope that it will get enforced. Now, I think forcing them into the preemptive option is worse, by far, than following a very clear directive. That is, in fact, the kind of reasoning, but not about food and water, that the Canadian Supreme Court just 3 weeks ago, used in this famous, now already famous Carter decision, where a person who could not, because of ALS, take lethal pills that she could manage to get her hands on, even if euthanasia is not legal, because she couldn't get them to her mouth and couldn't swallow. They said, if we didn't allow her to get assistance with the lethal drug, she would have to, her only choice would be to commit suicide earlier when she really didn't want to, all things considered. And therefore they backed up a right to later assistance. A lot of parallels here, I think, to food and water and severe dementia. The resistance case that you raised, I would ask to think about the reverse case, not the case where the family members want the person not to be fed and the person is appearing, maybe even they wrote the directive, not because they really wanted to die at that point, they said in their directive, but because they wanted not to be a burden to their family. But now imagine a reverse case where, and this happens, this is in real cases, the family wants to feed the person, even when they have a clear directive. And the family wanted the person not to write the directive saying withhold food and water to start with. Oh no, Mom, that would be terrible. No, I explain, why I'm writing the directive. I don't want to spend the last 3 years of my life at this. If that's the nature of their directive, they're not being, this is no exposure to an abuse. It's quite clear what the person's wishes. We do get to the fundamental question, which I haven't gone into here and don't have time to here, as to whether the withholding of food and water is tantamount to murder. First of all, tantamount to killing, and secondly, tantamount to murder. Got a full analysis of that, but I'll leave that to another time. Finally, critical interests, how are they determined? Should they be filtered by reasonableness? I think perhaps yes. Although we should think hard about that. Jehovah's Witness refuses blood transfusion and says in an advance directive, when I'm incapacitated, i.e. no longer a believing Jehovah's Witness, I want no blood transfusion. I order you not to give me a transfusion. You may think that's a whacked out position about transfusion. In some ways it doesn't seem very reasonable. Boy, it's culturally deep among Jehovah's Witnesses. I'm not saying your jihadist case is that, so I'm open to putting reasonableness filters on the implementation of an AD. Sure. And suppose a person wrote an AD that's blatantly prejudiced against all demented people. Would I enforce it? I don't. I think as a society we shouldn't.
You want to make some response first?
Asked me to respond to his question. I'll be very brief. I think my position is that because we can almost entirely ignore the critical interests in the advance directive, so we will take the will and the experiential interest of the now person. So I would say is that if the person seems to express, wish to have food, then feed the person. If the person is indifferent, but if the person seems to enjoy other things as well, then maybe we can still feed the person.
I saw 3 hands there, and Mr. Lam, right, and the lady behind him, and the lady before him.
Okay. Okay, I'm the sandwich. I'm the ham in the sandwich. 2 related questions here. The first one is it standard medical practice these days that once a patient is diagnosed as having dementia, that he or she be alerted to the option of writing an advance directive? Because my concern is, what if, on the first diagnosis, nobody told me, but 3 years later, when I become the then self, then I was told that I could have had that option, and I wouldn't even know how to decide for myself. So it's like medical practice is by moral standards, we should insist that once you've got this, you should be alerted on the first instance. It may be already 3 years into dementia, but you'd be alerted on the first instance. And related to this is, how informed can a person be? So when he gets diagnosed as a dementia patient. So in other words, do we have it would be best if there's like a half an hour video to show this is year 1, year 2, year 3, year 4, year 5. How is the slope slippery slope kind of gradual? Can it be steep? A lot of kind of stats so that somebody can make an informed choice. If I expect the deterioration to be very fast, then I may just sit back and wait for the slippery slope to descend very quickly and then cut off. But if the deterioration of critical interest is little, is gradual, then they may want to switch off, say, 5 years, 10 years from now. So I'm just wondering whether there's some kind of real factual stuff on the table for a patient to make informed choice early.
Well, I'd like to start by saying that I completely agree with your sliding scale approach. I intuitively and personally believe that is the right framework. However, I would think that it's very challenging to enforce, because at the end of the day, how would you decide at what point of that scale a person is in? Is that up to the doctor? Is it up to the family? How is it, just from the enforcement perspective, how can we ensure legal certainty? Thank you.
I have a question about sort of the anthropology as well as psychology of critical interest. On the anthropological side, to what extent do social taboos and values that are conditioned by current understanding of Alzheimer's and dementia affect the writing of these directives? If you think Alzheimer's is going to be unremittingly horrible and a burden, those are both huge negatives. But there's, if Alzheimer's doesn't fall under this huge social taboo, if you can look at it in a value-neutral way, would people write these directives differently? On the psychological side, this really relates to experiential, what you're calling the sort of experiential aspect. I would refer back to the discussion of soul and anima. To what extent, it seems to me that you need to add a component here of the soul or anima evolving during this experience. So what you're calling, minimal response and a little bit of happiness here and there may actually be tremendous joy on the part of the patient or the victim of Alzheimer's or dementia. And do we really know? Are we able to evaluate the psychological condition of Alzheimer's patients adequately, especially when we're standing outside?
Should we alert dementia patients to the possibility of writing an advance directive? Well, if we take a parallel like amyotrophic lateral sclerosis, ALS, upon a diagnosis of ALS, I think a person should, just of their own accord, and probably likely would, think seriously about what they want to have done in the unfolding situation. Should it be the medical profession or other caregivers' obligation to tell them about this possibility? Well, right now, if we take other advance directives, yes, there is some move in the United States to say that practitioners do have an obligation to have a discussion with people about not just near-term mortality, but some eventually impending mortality and what they want done. If I'm the general physician for a patient, I'd like to know some of the values of the patient. So some caregivers are bringing that up. Upon a person's diagnosis of a particular kind of progressive dementia, say Alzheimer's, and there are real diagnoses of this at certain points, which, if it gets a little bit into the dementia, can be quite secure diagnoses, I think it would be entirely appropriate to raise the question, do you have your things in order? What kind of directive do you want to get? Because progressive dementia, the patient needs to know, is going to progress. It's never going to go back up. It's going to go like this, plateau, drop, and it could be a 10-year process. That's a long time in your life. How do you want to prepare for it? I think it should be raised. And showing them a video, well, if they haven't seen Away From Her or Iris or Still Alice, which are hugely provocative and helpful movies on this, I don't know, I haven't thought about the video possibility. It certainly have to be a fair one. How do we enforce the sliding scale approach? Well, it's always difficult to know how to enforce an advance directive. We make these judgments all the time. One thing that lawyers in the United States advise is make sure you name a proxy, and that you say that proxy has the authority to interpret your advance directive. I don't know what it's, I think, a very morally complex situation. I don't know how to resolve that complexity without oversimplifying it in a way that wouldn't quite be fair to the later self or the earlier self. So I do think there are ways to work with that, but there are always going to be difficulties. We deal with them now in relation to all sorts of other delicate decisions. I don't see why we couldn't deal with them in this case. On the anthropological and psychological issues, yes, social taboos and values definitely affect what people see as their critical interests. I don't know how to avoid that. We're not beings who live without a society. We don't live in some societyless ether. We form our critical interests in a society. That's perfectly legitimate. We form it within religious traditions. We get more or sometimes less critical about those. I think we have to take, finally, people the way they are. Now, if their views are blatantly unreasonable, especially within their own culture in which they grew up, that's a different matter.
But you might want to add, not everybody needs to avoid severe dementia.
Exactly. People have very different attitudes toward this, and some of them, I think, can be very secure and very well thought out. As to whether the soul evolves, should we see it that way? I think that itself is a philosophical difference, not just a matter of empirical psychology. And I think an individual could believe, after having seen dementia up close in others, that in fact, this was not just a soul evolving. This was a withering life. This was a lingering life, not an evolving soul. And therefore, they didn't want their life to end in 3 or 4 years of that. I don't see why we should deny a person the intelligent expression of that choice and at least count their choice, even though they're no longer competent or aware of that choice, as part of the interest in their whole life. And this, after all, is the end of a whole life, and it will be seen that way.
I saw one hand, only one hand, right? So there's only one question.
Right, thank you very much, Professor. I'm really very impressed with the philosophical discourse in this afternoon. I also recognize the very obviously good intentions of developing these arguments to respect the person's autonomy, and no doubt that this is needs protection. But I can't help feeling very disturbed about the outcome of the conclusions, and I, in a way, share Professor De's, Dr. De's viewpoint that if we recognize this theory, then maybe one would have to admit that voluntary euthanasia must also be recognized. And I would almost go as far as to say that we already lost the battle in euthanasia, because as Professor Chan said, there are two selves. There's this old self and the new self. But for euthanasia, there's just one self, and that person is actually fully autonomous from beginning to end. So if we allow the old self to override the new self, in this sort of situations, then should we all the more recognize the right of the person to decide to end one's own life if they feel that their life is not worth living. And this autonomy should override everybody else's decision. So this is something which disturbs me, and I would be grateful for your expert opinion on this. The second comment I have is on the legal nature of the AD, the Advanced Directive, because I'm not sure what's the legal impact of this. If the Advanced Directive will override the decision of others, including the necessity of the principle of the doctors as well as other caregivers like the nurses, who would actually witness the forcible ending of life of the patient, despite others believing that the patient is actually living a happy life, even though they are in a demented state. So I'm sorry for taking up the time. Maybe I'll just end this. Thanks.
Since we have very little time, I pass time to Professor Menzel to have a short reply.
I would think that we should first look at the Dutch situation. Now, the Dutch situation, their legalization of euthanasia gets stereotyped as killing the people we want to get rid of. I would beg people to look carefully at it. I think most of the scholarship about it says it is not that. The Dutch, about 4 years ago, after having legalized euthanasia with various medical limitations on it, explicit consideration of the medical society, careful reporting of it, etc., decided that they needed to confront the question of whether a not now competent patient could be given euthanasia. They had previously considered that to be non-voluntary or even involuntary euthanasia, which they didn't want to touch. But then this case came up, which is in Bonnie's and my, described at some length in Bonnie's and my article, 2 years ago, old article. We called her Lutta in that case. She was in severe dementia. She was crying a lot, so you could argue that in her case she was suffering. She said, minimally, verbally, as much verbal as capacity as she had, no, not going into a nursing home when that prospect would be unfolded. With her distress and with her long-standing commitment, both pro-euthanasia in the battle for that in Holland, and with her directive that she did want euthanasia administered when she got to a certain level, not dementia per se, but a variety of other things, when she would no longer be competent. The physicians, putting it through numerous hurdles of review, decided that her clear advance wishes plus her current distress about continuing to live amounted to voluntary euthanasia if they were going to administer it. And they did. And that it's regarded as a very, it's a treacherous category. They review it very carefully. I think this should also be approached very carefully. Is it a line that we must not cross? That depends on other philosophical convictions one has about whether doctors should ever kill to help their patients, and other distinctions about killing versus letting die, etc. The Dutch have crossed those, and I think just like the state of Oregon and physician-assisted suicide, we're not seeing significant abuses. And if anything, maybe even an improvement in palliative care, because we've got to make sure that people are not asking for euthanasia because they didn't receive adequate palliative